We have been doing quality of life studies for a long time in Bergen, and are doing a prospective one too for the moment that is going on with interview of the patients before treatment and also with the control group, and we are following the patients, and we have followed the patients for 5-6 years up to now. And we are including the patients, and we have a special nurse who takes care of this, and also at the follow-up, which is important. You need someone who does this work for you, and also follow the patients after 3 months after during the treatment, 3 months after the treatment, 6 months, 1 year, etc. And she is really doing, she is a stipendiate for the moment and doing her thesis on this. These are the publications that we have written during the, since I think it is in the beginning of the 2000. And Birkhaug, for example, is one of the co-authors here. She is a laryngectomized patient that was one of my medical students, and she is a doctor now in the city. General practitioner, but now is specializing in children's psychiatry. She took part in that study. That was a national study looking at the quality of life for the laryngectomies in the National Society for Laryngectomies in Norway. Next slide. And there are some other studies, the recent one in European archives and the previous one in clinical otolaryngology. And next slide. And the questionnaires that we have used is the common questionnaires. We haven't used the questionnaires with the CTCAE that is recommended then for adverse effects, apparently, that we should comment upon too. But looking in the literature, for example, I could only find 12 papers on that in the PubMed, and I didn't know about this protocol before I came here. There are only 2 articles that are really deals with the head and neck. But all this we have used. In addition, we have used the Beck Depression Inventory, the Ising Personality Inventory, including a lie scale, and Spielberger's Trait Inventory State. Next slide. And the conclusions, this is a summation of all the papers, that is quality of life in laryngectomized patients, similar as general group for head and neck squamous cell carcinoma. And the laryngectomy patients are really doing fine when it comes to the global quality of life studies. We couldn't see that social support did not correlate with quality of life. You should expect that, but it didn't. And a high Beck Depression Inventory scores associated with a reduced quality of life. So you could really from the beginning say perhaps that these patients should not have a good quality of life after head and neck treatment. As has been said before, there are a lot of information in the present studies and questionnaires that can be used if we want to use them, that can foresee what quality of life the patients will have. There was a positive association between activity in the Norwegian Laryngectomy Society and quality of life. Next slide. Neuroticism scores were higher in head and neck squamous cell carcinoma patients than among controls. The control patients were patients admitted for benign diseases, and we made the interview just before doing laryngoscopy, etc., on these patients. Neuroticism correlated to alcohol intake. That is no wonder. And sense of humor predicted also quality of life, but it was a reverse one. The extrovert persons had a worse quality of life than the other ones, and had also correlated to depression levels at follow-up. And has been mentioned before too, coping is important. Especially the level of avoidance coping is inversely associated with head and neck health-related quality of life. That means that if the patient accepts their disease and do not try to avoid to think about it and have an avoidance thinking, they may have a better quality of life. And in this information, we perhaps should have some psychological teaching or information or some psychological treatment in the follow-up of patients. And I think that is perhaps a very important message. Next slide. We also had a TNM and type of therapy predicted quality of life score. The end stage was associated with a higher anxiety scores and depression levels. Neck irradiation and neck dissection were most closely associated to head and neck quality of life scores. Perhaps, as we have talked about today, more selective neck treatment is indicated, and perhaps more tailor-made treatment as a whole is more indicated for the patient. But treatment of the neck, either by neck irradiation or by neck dissection, were two major factors that influenced the quality of life for the patients. I think that was the end of it. Is there another one? No. Yeah, there is another study that I want to mention that is just published, that is a multi-center study in Scandinavia with Arbenstein from Trondheim, and it's people from Oslo, people from Malmö in Sweden, etc., that are involved, and also Kristin Bjordal, who has written a lot about the quality of life. Next slide. And they have used the regular protocols or questionnaires, and they have included 357 patients. And after the first year, there are still persisting side effects for the group as a whole, and some individuals had improved global health-related quality of life. Perhaps these studies and their conclusion is that using questionnaires like this, that can identify those individuals who need additional support and symptom relief. That was only a comment. That we perhaps already in our questionnaires have a lot of information that can be used more than have been performed up to now.
Thank you very much, Jan. We are at the end of a 2-day discussion about everything what can help our head and neck cancer patients. We heard from Lisa about quality of life after chemo and after radio, and now we are on the point surgery. And if we like to compare the data, we have a problem as we learn. We have at least 20 or more different tools we can work with, and we have different stages of the disease we are comparing. It's all a little bit mixed up. Can we find a way out, please? Kerry?
I think it's trying to find a way out of that is going to be difficult. I think that one of the things that we have to do is to have more people put the emphasis in to try to assess quality of life. Try to assess quality of life in its broad-based content as well as disease-specific content after surgical procedures. Assure that they're done before the institution of other forms of therapy. One thing that you can say about surgery is that surgical results generally can improve with time, but after they reach a certain nidus, they don't usually get worse after that. I mean, results can improve perhaps to 6 months sometimes with swallowing or function, but after that they're not going to get worse. And so the biggest problem is looking at the results of surgery alone. And the other issue that comes up all the time is that if we look at multiple forms of management of head and neck tumors that were heard about at this conference, surgery as an arm is kind of lacking in a lot of those.
René?
Yeah, I think the whole question of quality of life measurements is the last 10 years, many studies have been done, many resources have been driven into this research, and we really still don't know what to do with it. Most people who are active in this field, they feel that research is able to give answers for specific questions. Is this treatment better than the other treatment in general? But for the individual patient, it is always, of course, hard to predict whether he's on the left side of the spectrum or the other side. We recently finished a quality of life and functional study after a treatment for all and oropharyngeal cancer patients who were treated surgically, mostly with post-op IT. And indeed what we found, in contrast to what we expected, was that the quality of life after 6 months did not further improve to 1 year. And that was something that we expected, and we always tell our patients that after a year you reach a certain plateau. Well, you really have had it already at 6 months, and that's that then.
Johan?
Yes. The last study that Jan Olofsson referred to is a joint Norwegian-Swedish study, part of thesis, and it's a 5-year prospective follow-up. And during the first year there are some improvements, but then it usually is very stable. What is striking is that stiffness, trismus of the jaws increases, stickiness of the saliva increases, so they do not get better over a 5-year period. There is another aspect of this, and 1/3 has severe depression or anxiety. And I think we are very poor in addressing that. And what is more depressing in this, they made an intervention study in the Gothenburg part of this, that they tried to go in and by psychological and other means support these patients, but they didn't do better, though they tried to help them.
Mm-hmm. Klaus, would you like to comment?
First of all, I want to admire all these studies, especially what you said, Dr. Olsen. I think about the quality of life studies. I would say that it's very important to have the view on the perception of the patient's view of his disease and what's going on. But I would ask, really, we don't have it. We don't have it, and we will start it more strictly. But I would ask you, Jan, how did it change? Did it change your program? Did it change your treatment policy or the recommendation for the patients after these results of the quality of life studies?
I think what we have learned from this, why are we starting up to do for the first these quality of life studies? I think that we realized that the survival was nearly the same for a long period of time. We haven't improved survival. So at least we thought that we should have improved quality of life for our patients, because the new reconstruction type, etc., lower hospital stay, etc., might have also have some benefit for the patient, that they are coming out quicker from the hospital, etc., and that perhaps with modern treatment that the patient had a better quality of life. That is one thing, but we have very few previous studies to compare with. But if we start up now and have already then some baseline measurements, it may be easier then later on to compare if we change to, for example, chemoradiotherapy and see what problems they have. I think we also give the patients more information, because people say when they are coming that we didn't get the information of that, we didn't get the information that we have heard here. We can inform the patient a lot, and they perhaps only know half of it, even if you have been sitting down with the patient the day before, you know what you have told them. Because a cancer patient is blocked in the beginning. They get the diagnosis and they do not get the information. And they slowly get the information after surgery. They are interested for survival. But I think it's also a thing that they are getting better the health is going better, they are psychosocial getting better, and then they are looking for other things. So I think it is a sign of improvement for the patient. They have come over the first reaction, 1 or 2 years have elapsed, and we know that 80-90% of the recurrences are coming for that tumor after these years, and after that is the other multiple primaries that may be of importance. I think we are perhaps improving the information for the patient. We also have cancer nurses within the department that are regularly seeing the patients undergoing radiotherapy and giving information at the same time. Okay. We doctors have little time, I'm sorry, to sit down long time with the patients. I think this is we inform the nurses, and that has improved. So I think the information for the patients, what's going on the sequelae after the treatment, is much better.
We always do an informal consent with our patient before every surgery, before every chemotherapy, before radiotherapy, and is it like a catalog? If you look for your next trip in holidays, if you go to Finland, it is someone cold, and or in the desert it's very dry, and it is hot. But can definitively a patient who has to make the decision if he likes to have either a laryngectomy or a laser surgery, Wolfgang is not in the room anymore, or a combined treatment with everything, as we learned this afternoon, has he really a chance to compare what will be with him after 3 years? This should be, I think, the end point of the discussion of quality of life. And Chetin Shah showed me yesterday a drawing and said, look here, this is a patient stage 3. We diagnosed the case, here is the end of his life. Nothing changed in the last years about the overall survival. We should give him a chance to decide how he likes to live in this time, to give him a proper quality of life, and not, let's say, half a year in the hospital and then he dies. And this, if we can offer the patient tools like that, then we are at the end point of the quality of life discussion, I think. Please, Karl.
That there's one exception. That is, we have a group of laryngectomized patients, and we have what we call a self-helping group, self-helping group in German, and they are very useful. And for me, it was impossible to explain the patient what happens with, what are the sequelae of laryngectomy. But if they have the contact with this group and they discuss with them, he knows everything, and this is a very positive group. But this is the difference in our head and neck surgery, but I don't have any group for other severe head and neck diseases. So this situation is much complicated. If they have the larynx, they are not going to this group, but have the same, in the worst case, the same problems, because they can't speak, they have a cannula, and they have the larynx, and they are not attached to this self-helping group.
Yeah. That group is now in Norway, also includes those who are operated or treated for oral cavity, oropharyngeal cancers, etc., and also the tracheostomized patients. So there they have the same information, and I think this is really helpful. I think the decision is still mutual, even if they are informed. I don't think the patient really gets the full information, what you do. In the beginning, we never have written consents in Scandinavia, as far as I know. Not yet, it will come. But even the written text and information to patients, they read it very seldom carefully. I think you need personal communication, etc. And even if you inform patients about the different options that are available, it ends up with what do you as a doctor recommend. And then I think you have mutual contact with the patient, which is perhaps the best thing for the whole procedure and what is coming later, then they trust you as a person and as a doctor. And if it's coming like that, and I say, if it had been my father or if it had been me, I had done that and that and that. And they say, we follow that.
Any comments from the
90%
Jeffrey?
of patients do it. Some such second opinion.
I want to congratulate Dr. Olson on a very excellent presentation that really pointed out a lot of the complexity of this area, and there were a lot of poignant cases. I wanted to ask him about his friend that he played squash with. Was he treated in your center or was he treated elsewhere?
It's treated elsewhere.
Okay, so I'd like to make a point about that, and that is where people are treated and the modalities they receive matters maybe as much as the modalities they receive. Because, you know, you showed a very nice example of a patient you treated with surgery and radiation after, and then your friend decided to go somewhere else and got chemoradiation. But in our center, at your center, or, you know, any of the centers represented here with a well-focused multidisciplinary treatment and rehabilitation team, he may not have ended up with a 10-centimeter stenosis. And I think it's a critical point. And we can't generalize these treatments that we're showing here to small places that aren't set up to treat and rehabilitate people properly. And if that, our philosophy is to evaluate patients prior to therapy as a multidisciplinary team that includes not only the oncologist, but the speech pathologist, the dental oncologist, and other members of the rehabilitation team so that they get optimal outcomes with either modality. And we see patients referred in, treated elsewhere that had bad surgery or bad radiation or bad chemoradiotherapy, and they all have problems. So I think you know, where and how they're treated matters as much as which treatment they received.
Thank you very much. Johan?
Well, there is an ethical question in this. We are increasing survival with 1 or 2% or 3%. With a tougher treatment, and then we increase or decrease the quality of life for the survivors with about 20%. So if we increase the cure from 50 to 53%, you have 3 people who benefit and 50 people who bear the burden of a severely decreased quality of life.
Yeah, that's right. Carlos?
I think we should also discuss if surgery and everything is okay, then we have to discuss it. But we have also discussed the patients who were not lucky and who have a bad result. And it's okay, you create a team, but who is then responsible for his last months? You know? Who takes care of them? Take for tracheostomy in the case of feeding and all the problems, you know. Who says where should they be cured? Not failure. What does it mean? Where they take the care of? Who takes the care of the patient, of the long dying process of the patients? Who says now we finish therapy? Who is responsible for this? The team? I think in my feeling it was always the surgeon, it was the ENT surgeon. The patients were operated in my hospital, in my department, they were treated and they come back, and if they have difficulty, and they finally died here. And I think, maybe I cannot express it very strictly in my English, it's too bad, but we have to discuss this. I think this is also an important point. Who is responsible? Who feels responsible in the last
Jan and
final
Kerry?
stages?
I think we need, firstly, there are very few quality of life studies that are studying those who are not surviving. I think we should really look at perhaps the 50% of the patients who succumb to their disease and what they suffer during the time before for death.
Who takes care?
And in our place, it is we who have the primary responsibility, and then there are palliative teams too. But I think the palliative teams has to be more built out, and that we can refer them to. We have pain teams, etc. But still, it is we in the ENT department that usually takes care of them or send them away to a central hospital to another ENT. And another thing I think is very important for quality of life, because there was a Turkish study on laryngectomized patients that said that they did not have a very good quality of life. And I think the insurance system is very different in different European countries too. If you have a very good insurance system, they do not have any economically problems if they're living in the Scandinavian countries. But apparently in Turkey, in this article, they had problems to support themselves economically. Yeah. And I think that is also, if they get that above, to lose their voice and etc., and all the other problems.
Before I ask Kerry, we had before the discussion about assisted suicide, and I think we are at a point of the discussion, Klaus mentioned it, where we should also inform the patient if it is, as always, maybe you have to live 6 weeks or you have to live 2 months and so on. Do you like to have another chemo? Do you like another salvage, I don't know what? Or do you like to die? And we had a discussion before in some countries, in some states of the United States, there are doors open for that. In Europe, it's in the Netherlands and in Switzerland and so on. And I think it is ethical, in my feeling, to be a doctor. It is also very important not only to offer always a new treatment, but also to inform the patient that it is time to go. Please, Kerry.
I think that end-of-life discussions and treatments are an extremely important part of any physician, and especially any physician, regardless of their specialty, that deals with cancer patients should be well-versed and comfortable in palliative care. I think that's an important part of our field. It's an important part of life. It's something every one of us is going to go through at some time. And I think the biggest fear patients have is pain, and I think they need to be reassured that they should not have to have pain. I think that one of the things that I try to do is to be very open and honest when I don't think patients should pursue other forms of treatment, when they should not have another operation, where they should not have to go chemotherapy, where they should not have something else done. And I try to, at that point in time, try to involve our patients in hospice programs, which I think are excellent, especially home hospice programs, which allow them to die in their home environment with their family. And they have tremendous benefits by going into those programs in terms of governmental support for payments of drugs and funds, and they bring in excellent people that can help them. And I tell them they need to get a physician in their home area, because many of my patients come from a distance, and even if they're 50 miles away, they may have a family practitioner or somebody who will help them out again with pain medications. But there's no question they know that they can always come back and see me at any time, and I'm always willing to see them. One of the interesting things that one of my good friends who's a medical oncologist has said was, we talked about quality of life and issues with patients, is he's always commented about the fact that the patients with cancers, and especially those who die of cancers, that seem to do best and seem to have the best quality of care are those individuals who are married as opposed to single, those who have a strong religious faith as opposed to not religious faith, those who have a good social interaction with friends as opposed to being alone, those who do not fear pain because they know their physicians are going to take care of pain, and lastly, those that have a dog. So I tell all my patients, get a dog, get a good wife or husband, get a lot of friends, start going to church or synagogue or whatever your religious background is, and don't worry, we'll take care of the pain.
It may be too late then.
That's right.
It sounds like an end point, but maybe, René, do you say something from the Netherlands point of view?
Yeah, I think you point to an important factor, that the patient has to be reassured that you are there for him. And in that respect also, since the last couple of years, under very, very strict circumstances, it is allowed in my country and in a few others in Europe to do active euthanasia. And in that sense, you only postpone death by 1 or 2 months or something. And it's only under very, very strict circumstances. But we don't often do it. In the past, we had many more patients in the ward who were on morphine than that we have to do active euthanasia nowadays. It happens maybe 2 or 3 times per year in my unit, and we see many cases. So it's more a matter of reassuring the patient that you are there until the end. That itself gives already the relief than to actually do it. And we do it very, very rarely.
Thank you very much. I think it's time to close this session. I thank the panelists and our speaker, and I thank especially the organizers again, Professor Knecht, and Dr. Hamburg and Professor Stöttner. Also, if you allow, in the name of the German Society of Otorhinolaryngology, Head and Neck Surgery, we are proud that you all followed the invitation of this gentleman to come to Frankfurt, and we had the chance to share with you your knowledge, your experience about cancer and new modalities and how to apply them. Thank you very much.